thank you for this invitation to be with you this morning and today. And it's good to be with friends again, listening Professor Shaha and Professor Dewan. And I have been informed about the Kuala project, the long-term research project, and I congratulate all of you, many of you who are involved in the project for the successful completion of this project. And I look forward to looking at the results of this very interesting and important research project that we have taken through. So I'm going to share with you some of the findings as regards cognitive health of older persons in the Singapore Longitudinal Aging Studies Cohort, which I will be describing to you in more detail later on. And very briefly, by way of introduction, very briefly, since we are talking about cognitive health, we are actually interested in dementia because, and dementia, you know, many people in the world know now that it places a very heavy burden of care on society all over the world. And vital to the national strategy for dementia control and dementia prevention is the fact that we must aim to improve and maintain the cognitive health of older people, of people at the age. So that's the reason why we are looking at cognitive health, because by improving cognitive health, it helps greatly in preventing the more devastating and disabling condition called dementia, which poses a tremendous burden of care and resources on societies and the healthcare system. And a better understanding of what causes dementia and what causes cognitive decline to older people. We can get it from population-based longitudinal cohort studies. And that's why we are here today talking about cohort studies of older people and following them up as they age and studying their cognitive health and dementia. Again, very briefly, we will look at the prevalence of dementia worldwide. In just in the very recent year, we have about 35 million cases of dementia worldwide, and that means it's about 7 or 8 million cases of dementia every year. New cases comes up once every 4 seconds, and the important point to note about dementia prevalence is that the number of cases of people with dementia will increase exponentially over the next 20 years. And that's the result of population aging and mainly. Also, another very important thing to note is that we tend to think of dementia as a problem of advanced, developed countries, rich countries, high-income countries. But we must remember the fact that because the largest numbers of old people in the world are found in Asia, therefore, the majority of people with dementia, persons with dementia in the world are actually found in low-income, developing countries. And because of Asia has the largest population in the world, Asia will have the largest number of people with dementia. And so that's very important to note. And that the increase will be very, very great for Asia because population aging is far faster in Asia and in developing low-income countries than in the Western country. So we do have a much greater problem with population aging and with dementia than in Western country. And so that's a very important challenge that we have to face, and we have to face it very early and very quickly because of the fast rate of population aging. We have very little time to adapt to those changes. Just to give you an example from Singapore in terms of population aging. Presently, the proportion of older people aged 65 and above is about 10 or 11% already. So but in 15 years' time, 2030, 19 to 20% of old people of the population will be over 65 years old. And that's a very short period of time between now and 2030, only 15 years. By 2025, the population of Singapore will actually shrink. And whereas the dependency ratio right now is 6 working persons to 1 older person, by the year 2030, in 15 years' time, or 2025, there will be only be about 2 or 3 working adults to 1 older person. So that's the severity problem. So, and then the economic impact of dementia is tremendous, and you can see some of these numbers here. They are astounding. For example, you can see that it represents 1% of world GDP. The worldwide, most of the cost of dementia care actually falls in developed countries. The cost of care for dementia is much greater in developed countries, and the cost of care for dementia is less in countries in this part of the world. And that's largely because most of the care in our part of the world is taken over by informal caregivers, families, and social community, and so forth. Whereas in Western countries, we see a lot more older people who are in institutional care. Like in Sweden, for instance, 50 to 60, 70% of old people actually live in nursing home. Whereas in Singapore, less than 1% or so, actually are in nursing home and hospital care. So most of the care or cost of care is direct care, and that's the most expensive part. Whereas in our part of the world, cost of direct care due to hospital care and nursing home care is because we keep most of our dementia patients at home rather than in nursing home. But over time, we cannot avoid the fact that we will, because of family changes, of nuclearization of the family, and the shrinking working adult support base, we will have to face the fact that we will have to place more and more of our older people with dementia in institutional care. This is what dementia looks like, and I don't have enough time to talk in detail about dementia, but basically what we see in dementia is a shrinking of the brain. And that shrinking is of various degrees depending on the state and which dementia develops. And they are due to multiple causes. And the most two important causes are due to Alzheimer's disease, neurodegeneration, and the other one cause is called vascular dementia due to several vascular disease of the brain. And the largest proportion is actually mixed Alzheimer's disease and vascular dementia. There is no curative treatment or no cure for dementia, Alzheimer's disease. We do have available drugs, but they have very limited effectiveness. Drugs like omeprazole and so on are only good for about a year, and after that, most patients don't feel experience any more benefit from using the drug. It does therefore it's very important to think of ways and means in which we can slow down the rate of cognitive decline and in order to prevent dementia. It has been estimated that if we slow down the cognitive decline and delay the age of onset of dementia by 2 years, we can reduce the prevalence by 20%. Or if we delay the onset of dementia by 5 years, we can actually halve the prevalence of dementia. That makes a tremendous impact. This is what I mean when we look at This is age from about 20 to 80 years old, and this is the level of cognitive functioning. And what you see here is their cognitive decline. This is age-associated cognitive decline, and this is accelerated cognitive decline. And this is really what we mean by cognitive decline. This is cognitive aging, and you can see that with normal aging, cognitive decline does not reach a level where it causes any problem. Disability, problem in memory and functioning and so on, and communication and so on. However, if the cognitive decline is very rapid, it will reach a threshold when it causes symptoms, and that symptom will therefore cause disablement. And this is when we begin to see early signs of dementia, like forgetfulness and poor and functioning, and the lower the cognitive function level, the greater the severity of cognitive impairment. This is where we begin to diagnose dementia. Causes of dementia that we see here. This is Alzheimer's disease pathology. Essentially, two main pathology here. This is called amyloid deposit, and this is the neurofibrillary plaque that are present in the nerve cell in your neuron. The other main pathology called is small vessel disease in the brain, which are not large enough to cause stroke if we recognize that, but very often it gives rise to all kinds of cognitive problems, and this is, we sometimes call them small vessel disease here. So, and very quickly, so here we see that this is this is dementia, and this is an early stage of dementia, which we call which is the pre-dementia syndrome. We refer to it as mild cognitive impairment. The current DSM classification now refers to this as major neurocognitive disorder and minor neurocognitive disorder. They're pretty much the same. What's important to note that when you're talking about amyloid deposits in the brain, which is the underlying, which is believed to be the main underlying pathological cause of our Alzheimer's disease, is that even before we recognize dementia and mild cognitive impairment, asymptomatically, we are already seeing increasing deposits and burden of the amyloid plaques in the brain. And here. And so these in the blue line, we also begin to see brain shrinking as well, very mild brain shrinking, and so on. So we see these early changes already taking place even before we recognize dementia. But we cannot see them clinically, but we can detect them either with MRI and blood biomarkers. So, how can we control dementia? One way is to slow cognitive decline by modifying the underlying AD or cardiovascular disease pathological process, by modifying the underlying disease process, or by increased brain and cognitive reserve to create a circular buffering capacity. This is what I mean here. This is cognitive aging, and this is cognitive loss, cognitive decline here. And this is what we can do if we slow the cognitive decline by addressing the underlying pathology here. And therefore we delay the onset of symptoms by several years, so that the age of onset of dementia is later. The other approach is to alter the threshold, increase the buffering capacity by lowering the threshold from here to here, down here. So originally it was there, here. And so we also delay the onset of symptoms. So increasing the buffering capacity of the brain. This we call it cognitive reserve, increasing the cognitive reserve. Also, another important point to note is that the factors and the causes of dementia took a life course to develop. So the causes of dementia originate actually from birth. And there are many psychosocial factors, risk factors that contribute to the level of cognitive functioning and cognitive reserve, and they are also in midlife factors, especially cardiovascular risk factors, which contribute to the onset of development of dementia, Alzheimer's disease or vascular dementia, and only in later life that we begin to see early signs of changes and late signs of changes in dementia. So, summary of some of the risk factors that we know of that and protective factors for dementia are here. They include genetics, and the principal major genetic factor to date is the ApoE4. This is very well established. Then there are demographic factors, especially age. Female sex is a little controversial and not uncertain, and very importantly, education, as we shall see very clearly later on in many presentations. Lifestyle factors, especially physical activity, social factors, especially social isolation or engagement, and that includes being married or not being not married, being widowed, etc. And active employment, anything that is social, psychologically activity, that's another factor. And so that includes cognitive stimulating activity, also psychological factors, especially depression, and medical factors. That include age injuries, and many other conditions, drugs. And then there are vascular factors or cardiovascular risk factors, smoking, obesity, hypertension, diabetes, insulin resistance, and the metabolic syndrome. And then there is finally but not least, nutritional factors that include folate, B12, omega-3, and others as well. So to give you a snapshot of the many protective and risk factors that are involved in the development of dementia. This is the Singapore longitudinal aging study, and what we did was that in the year 2003, 2004, we began to recruit a cohort of older people who are aged 55 and above in this area of Singapore in the southeast, and we went door to door and in that cohort and identified all older people in that area, and we interviewed them on 5 separate occasions with a questionnaires, many questionnaires at home, and then we invited them to come to a local study site where they spend one morning doing all the tests that include blood pressure, ECG, physical performance tests, walking, gait, muscle strength, cognitive testing as well, and so forth. And then this cohort has been followed up twice at 3 yearly intervals. So the second follow-up at 6 years has been completed, and we will be embarking on the third follow-up at 9 or 10 years. The second cohort of another 3,000 in this southeast and western area use the same research methodology, and this cohort is now going to first follow-up at 3 years. This shows you a list of the kind of testing and assessment and questionnaire that were conducted on these participants. And these are the baseline measures that were collected, and they cover these different domains such as psychological, lifestyle factors, behavioral factors, medical, physiological, and physical functioning, psychological, and neurocognitive. So neurocognitive testing alone is done separately in yet another occasion, taking at least 1 to 2 hours. And at follow-up, these were the measures that were assessed, mainly neurocognitive, dementia, depression, physical functioning, frailty, ADL, quality of life, and healthcare use, and mortality. So very quickly, how do you measure cognitive health and measure cognitive outcome? Essentially, we focus on measuring cognitive impairment and cognitive decline by using measures such as MMSE and by serial change in MMSE, for instance, to measure cognitive decline. We identify cases of mild cognitive impairment from the neurocognitive test metric. And then we also aim to determine the rate of conversion from MCI to dementia. And we also identify cases of dementia and aim to diagnose Alzheimer's disease, vascular dementia, and mixed dementia. And these were the tools that we use, that you can hear, that include the MMSE, include the and then the CDR, clinical dementia rating, which is administered by trained nurses. And we diagnose dementia using these criteria here, as you can see here. Essentially, based on MMSE, neurocognitive test, clinical dementia rating, and ADL dependence. And these are some of the research findings. These findings relate to social demographic factors, leisure time activity, psychological factors, depression, cardiovascular and metabolic risk factors, physical frailty, undernutrition and overnutrition, nutrient factors such as folate, B12, etc. And the first finding about dementia prevalence. We see here you see the prevalence of dementia. Overall, it's about 6% in this cohort. But if you break them up into by sex and by race, we find that male sex, female sex have a higher prevalence of dementia, and then between Chinese and Malaysian Indian, age for age and sex for sex, Malaysian Indian, you can see very clearly, each of these age and sex groups, Malaysian Indian have higher prevalence of dementia. I think this has also been found in the studies here in Malaysia very recently. And the ethnic differences that you can see here, as you compare Chinese and Malaysian Indian, you can see the dementia prevalence higher in Malaysian Indian. Interestingly, you can see that it has only 4 prevalence in Malay, and that's one contributing factor to higher prevalence of dementia, especially Alzheimer's disease and so on. Then there are other factors that are different between ethnic groups. So altogether, there are these other factors that contribute to ethnic differences in the prevalence and the risk of dementia. One important factor, which I found very powerful, and is this. If you look at the MMSE score, the higher the MMSE score, the better performance, better cognitive health. And here you can see comparing Chinese, Malay, and Indian here. This is no education group, this is primary education group, and this is secondary education group. You can see that cognitive performance, MMSE performance is better in Chinese than in Malaysian Indian, significantly more so, by at least 2-3 points here. And these are adjusted for age. You can see in a non-education group. In a primary education group, you see the similar difference, but the difference becomes smaller. Or among the secondary education group, you see no difference at all in the cognitive performance among Chinese and Malaysian Indians. So this emphasizes the very powerful influence of education, or more accurately, lifelong cognitive stimulation and learning. And that underlies the reason why that we emphasize so much about lifelong learning and continue to learn new things when we are older. So that's very important, I think, take home public health message that we must bring to our older people in the population. They must keep learning new things. If they don't have education when you're young, it doesn't mean that you cannot learn things, because the purpose of education is to make you learn, not to get a degree. Yeah? So that's a very important lesson. Lifestyle and behavioral factors, very importantly, what we do in our leisure time, physically, socially, and as well as mentally, very important. And that includes, social activity, many social activities, and include mentally stimulating activities, including staying employed, working. That's quite important. If you just look at these are 3 groups, different levels leisure time activity, all of three categories. You can see the higher the level of leisure time, higher the level of leisure time activity, the risk of cognitive decline is much less, 0.6 to about 40% less. And compared to those with lower level of activity. And comparing productive activity with social activity and physical activity, all of them, each of these different types of activity are associated with a lower risk of cognitive decline. This is about 25%, this is about 20%, this is about 30 over 33%. And productive activity, which include any sort of activities, including continued working, volunteering, and continued employment, that's productive activity. And so essentially reflecting mental activity. That's associated, appear to be even much greater impact on cognitive decline. And this is when we break them up into two groups. Those who carry the ApoE4 gene and those who do not carry the ApoE4 gene. There is a difference too. The impact of this leisure time activity on cognitive health is much greater, adversely, negatively, in those who carry the E4 gene. Yeah. This is an interesting experiment which is very well known already, and it explains an important concept. And that concept is the concept of brain plasticity. This theory says that the brain can grow can regenerate. The brain is not plastic. The number of brain cells does not remain constant. But the brain, you can see in this experiment here, in the mice that are raised, these are old mice in the standard case, and these are also old mice raised in a different environment. This is what they call an enriched environment, where the mice are allowed free range of non-physical activity and play. And you can see the difference here in the neuron. You can see the neurons here and the neurons here. This neuron here is very rich. They have rich arborization. That underlies brain plasticity. What we also see, and which reflects the importance of cognitive engagement and social engagement. That another aspect is that is in marriage. The emotional support and connectedness from a close relationship in a marriage appears to be quite important for confers a protective effect. You can see from this, from the chart here, yeah, because I can't see that very well from there, so I'm yeah, that's thank you. I think this is okay now. Yeah, I think this is okay. Yeah. Okay, good. So here, feel better this way. Yeah, you can see that compared to those who are married, those who are single are 6 times more likely to develop cognitive impairment. That is from cognitive impairment. Those who are widowed about 5 times, 5 to 6 times more, and those who are widowed especially singles and divorced. And this suggests, and these are all controlled for many other factors. And this suggests that this of course data tells you that those, especially those who lost a spouse and widowed and single, they are more cognitively impaired. Conversely, those who remain married and stay in a marital relationship seem to be better protected against cognitive impairment. And possibly, and very likely, a few other studies in Finland have also shown that they are less likely to develop dementia. We may talk about why I say that it should be so later on. This This illustrates cognitive decline in three groups of people: one who are retired without voluntary work, those who are retired with voluntary work, and those who are still working. And I can see we are measuring cognitive decline here. There's a lower rate of cognitive decline for those who continue to work compared to those who are just retired and so-called doing nothing. Yeah. Another factor is this psychological factor is depression. Depression is associated with the risk of cognitive impairment. And you can see, and that is particularly among men, and also among those who carry the E4 gene, ApoE4 genes. Nutritional factors, we studied by now quite a number of nutritional factors, and they include undernutrition here and overnutrition, including metabolic syndrome. Dietary patterns we didn't study, but just for completeness, we should know that dietary patterns seem to also have an effect. Specific micronutrients and functional food and phytochemicals such as tea, polyphenols, and others. So these are some of the findings here. If we look at the nutritional risk status, and this measures is over here. Yeah. So I hope I don't wrong any of you. Oh, I think this is better now, huh? Then I can put here. It's better now. Okay, so here you see two groups. One who are at risk of malnutrition, and we use a scale which is very commonly used. This is similar to the MNA, but this is used by the American when it first started. We ask questions like whether they have enough tea, whether they eat alone, etc., whether they are poor, and so on. And so on. So this is a risk of malnutrition. You can see the MMIT scores is lower for those who are at risk and compared to those who are not. And here you can see here using looking at this is hemoglobin, levels of hemoglobin. You can see a relationship between the levels of hemoglobin of anemia with cognitive impairment. You also see that with albumin as well. And you can see that the lower the albumin, the greater the likelihood of cognitive decline. And this appears to be particularly so for those who carry the ApoE4 genes here. And this is physical frailty. Physical frailty increases the risk of dementia. Here in the data here, we categorize the subject into those who are robust, who are pre-frail and frail in these three groups. You can see here that there's a difference in the odds ratio of cognitive impairment in those who are frail, much greater than those who are robust here. And also for the likelihood of MCI dementia, there is a greater risk of dementia and MCI in those who are frail compared to those who are robust. And if you look at these groups together, you can see that already this is quite evident that those who are frail are more likely, 50 over time, more likely to be ADL dependent, ADL disability. 3 times more likely than those who are robust to be hospitalized, and who have 17 times more likely to have low quality of life. If you combine frailty status with cognitive impairment and compare that with those who are without cognitive impairment, this is the most healthy group, and this is the most extreme group, which is both frail and cognitive impaired. You can see that there's a gradient of relationship here. You see from 1 to 2 to 5, 30 to 76. This group here is 70 over time more likely to be disabled compared to those who are robust with cognitive impairment. 4 times more likely to be hospitalized, and 50 over time. Very clearly, you see a frail person who is also cognitively impaired, and not necessarily could have been diagnosed with dementia, may not be diagnosed with dementia. According to this data here, they are at very high risk of this adverse health outcome. This is what everybody here already knows. This is what a modern diet looks like. High in calories, sugar, saturated fat, and trans fatty acid, low in mono and polyunsaturated fatty acid, high in salt, low in fiber, little in vegetable. And these are have been shown to be associated with the metabolic syndrome, which is a cluster of cardiometabolic and cardiovascular risk factors. The most defining criteria is central obesity, and that is also associated with abnormal glucose metabolism, cholesterol, and hypertension. And it has been shown the metabolic syndrome increases the risk for diabetes and cardiovascular disease as well. The underlying pathology is insulin resistance. So these are what we observe. In those without, this is incident MCI from follow-up over 6 years. New cases of MCI among those who were free of MCI and free of dementia at baseline. Again, these are the no metabolic syndrome. These are the ones with metabolic syndrome. There's a difference in the rate of MCI, about 50% more increase in those with the metabolic syndrome. And this, what you see here, is that among those with MCI, those with metabolic syndrome are more likely, 4 times more likely to progress to dementia among those with metabolic syndrome. And this shows the different components of metabolic syndrome that are increased, particularly diabetes, is very clearly so. So diabetes is associated with a 2 to 3 times increased incidence of MCI, and also 3 times likelihood of progressing from MCI to dementia among those who have MCI and diabetics. This is diabetes. So as you can see here, diabetics not only have higher level of MCI. So if you see diabetic patients, you are more likely to observe MCI together at the same time, and also more likely to observe more dementia from them. And the risk of developing MCI is also greater, 2.5 times more likely to develop MCI, and 3 to 4 times more likely to develop dementia. This is what we can expect, at least based on the data we have got. If we treat MCI, treat diabetes with metformin, and in the study population, we asked questions about whether they were on metformin, and among the diabetics, and those who are, there are a group of diabetics who are not on treatment, because there's still a population, a subgroup of diabetics who are not on any treatment at all. Yeah. And or may not be on metformin. Those who are less than 6 years and those who are over 6, you can see appears to be a relationship between metformin treatment and duration of metformin treatment and the likelihood of developing incident cognitive impairment in this data. The other nutritional factor we looked at is not dietary factors, but micronutrients and phytochemicals. Here we see again this is what we know to be a healthy dietary factor. Diet, the Mediterranean diet. The other healthy dietary factors that is recommended is of course the DASH diet for hypertension and so on. But the other healthy diet that we know of is the Okinawan diet. It should be possible for all of us, and we haven't done it yet, to actually look at our food intake pattern and determine what would be a healthy dietary food intake pattern. And our increase in Asian diet. Because we are not Japanese, but you can see the Okinawan diet, it looks to you that actually this is a poor man's diet. Yeah. The Mediterranean diet, some of us are actually trying to adhere to the Mediterranean diet. So it should be possible in our population to determine the degree of adherence to a healthy diet, Mediterranean-like diet, and so forth. We haven't done that yet. This is, but other studies have shown that for people who are adherent to Mediterranean diet, a higher level of adherence, the risk of Alzheimer's disease is less by about 40%. We don't know what is Asian diet, and we should look at that. Folate, B12, and homocysteine is another matter of interest. We don't have time to go into the metabolism, but essentially, what folate, B12, and homocysteine are very closely connected because they're all in the carbon-4 cycle. And you can see here they are important for neuroprotection. You can see here that the higher the level of folate, the lower the risk of cognitive decline. And you can see that too when you measure relate serum folate with cognitive function here. The higher the level of serum folate, the greater the memory recall, they remember more and they forget less. Also, there's a relationship with plasma homocysteine. Higher level of plasma homocysteine is associated with poorer performance on processing speed and visual vision. You can also see that with brain volume, like this one for instance. This is the level of homocysteine, and this is the brain volume. This is several white matter brain volume. You can see the higher level of homocysteine, the lower the cerebrovascular, white matter volume. You also see a relationship with B12, particularly among those who carry the A4 gene on the performance of the digit span and memory. Omega-3, we don't have time to go into the biology here, but omega-3 in summary, as you know, has very powerful antioxidant and anti-inflammatory properties. And you can see here that in the group here, with daily consumption of omega-3 supplements here, they are much less likely to show cognitive impairment. And this is what we found with level of tea intake. High level of tea intake is associated with lower risk of decline here. And this supports the earlier first study done by the Japanese here, where they also see that relationship with green tea. And you can see the relationship between tea intake and different neurocognitive domains here, and they all form. We see no difference between black and oolong tea or green tea. They all have the same positive effect on cognitive functioning, but no effect of coffee. And definitely that looks like a control that you can look at. There's a Chinese longitudinal healthy age longevity study with a very large population. They have also, after they shown that as well with their data.